Hello, and welcome to our webinar on cognitive assessment and care plan services. My name is Jennifer Boniface, and I am one of the nurse analysts from the Provider Outreach and Education team. Today's webinar will focus on the CPT code 99483, Cognitive Assessment and Care Plan Services. I have a few housekeeping items to go over with you before we start the webinar. You can find the link to the encore presentation of this webinar on our website's Training Center page at www.wpsgha.com. It will be accessible for the next 60 to 90 days. Additionally, the recording will be uploaded to our YouTube channel under the Encore Presentations playlist, and both should be available within the next 15 business days. If you have any questions, please put those questions in the chat feature and select Send to all panelists. We will answer questions as time permits. Should we be unable to answer a question during the webinar, we will create a follow-up document and send it to all attendees afterward. We really want your feedback. It helps us develop the education on topics that may be of interest to you. Consider taking our survey to let CMS know what you did like and what topics you'd like to learn more about. And Mary Sue will place a link to the survey into the chat. There will also be an opportunity at the end to take the survey. Additionally, you can provide feedback by completing the survey while viewing the encore presentation. To access the survey, click the circle with the eye in the upper right corner of the video. A link to the survey can also be found in the description of the video. On this next slide, we have our disclaimer. Medicare rules change often, so please make sure you're looking at official CMS communications for the most up-to-date rules and regulations. These do take precedence over anything that is presented today. And as a reminder, CMS prohibits recording of this presentation for profit-making purposes. This presentation is being recorded by us and will be posted on the Training Center page of our website under Encore Presentations, as well as on our YouTube channel under the playlist Encore Presentations. This slide contains the CPT copyright notice, and this is a requirement to be provided to you since we do use CPT codes within this presentation. Please review this information at your convenience. On this slide, you'll see a list of acronyms used in this presentation. During this presentation, if there are any acronyms you are unfamiliar with, please take a look at this slide for the definition. Cognitive impairment is a decline in mental functions like memory, attention, language, reasoning, and problem solving. While some cognitive decline is a normal part of aging, cognitive impairment is not. Cognitive impairment disrupts a person's capacity to live independently and perform daily tasks successfully. The National Institutes of Health reports that about 2 of every 3 Americans experience some level of cognitive impairment, typically starting around age 70. Our objective for today is to provide an overview of Medicare's cognitive assessment and care plan services. We will cover background information about cognitive assessment, Medicare coverage criteria and documentation guidelines for 99483 cognitive assessment and care plan services, and billing for CPT code 99483 cognitive assessment and care plan services. Let's first start with some facts and statistics about cognitive impairment. According to the Alzheimer's Association, in 2022, about 12% to 18% of individuals aged 60 or older were living with mild cognitive impairment. Each year, an estimated 10 to 15% of individuals with mild cognitive impairment develop dementia. Among those with mild cognitive impairment due to Alzheimer's disease, around 33% will develop dementia within 5 years. The National Institutes of Health report that Black individuals and those with lower levels of education tend to experience cognitive impairment at an earlier age, face a higher lifetime risk, and live a cognitive decline for a longer duration. And this may be attributed to factors such as limited or unequal access to healthcare or socioeconomic challenges. So what is cognitive impairment? Cognitive impairment refers to difficulties with thinking, learning, memory, judgment, and decision-making. It can include challenges with memory, learning new information, concentration, managing finances, and making everyday decisions. These issues can play a significant role in the person's overall health and well-being. Cognitive impairment can fluctuate, ranging from mild to severe or anywhere in between. Age-related cognitive impairment is characterized in 4 levels, including no cognitive impairment, subjective cognitive impairment, mild cognitive impairment, and severe cognitive impairment. Severe cognitive impairment is also referred to as dementia. And I'm going to go give you a brief overview of each level so you can understand what each one includes. The no cognitive impairment stage refers to individuals undergoing normal aging or those with a cognitive disorder that is not severe enough to affect their cognitive abilities. There is little to no decline in cognition or cognitive abilities for the person in this stage. Individuals in this stage have normal attention spans, memory, and problem-solving skills, and can function without difficulty. The individual may present with some age-related changes to the brain, but these changes do not adversely affect the individual's ability to function. In the subjective cognitive impairment stage, individuals may notice a decline in cognitive or functional abilities, but they can still compensate for these changes and continue managing daily life, including more complex activities without significant disruption. During the mild cognitive impairment stage, memory and cognitive impairment have gone beyond what is usually seen as a normal part of aging. Individuals with mild cognitive impairment can typically live independently, particularly when carrying out familiar tasks or in environments they know well. However, they may find it challenging to deal with new situations, especially those requiring learning or adapting to unfamiliar situations and scenarios. It's important to mention that while many individuals with mild cognitive impairment may eventually develop dementia, not all people with mild cognitive impairment will progress to severe cognitive decline or dementia. Some may remain stable or even experience improvement in their cognitive and function over time. Finally, during the severe cognitive impairment stage, also known as the dementia stage, individuals present with a significant decline in cognitive abilities, including notable difficulties with memory, judgment, decision-making, and language skills. They begin to struggle with everyday tasks and activities of daily living, including ones they previously mastered. As a result, they require assistance from others to manage them. As this stage advances, language skills continue to deteriorate, and individuals may no longer recognize familiar faces they once knew. Finally, as the dementia stage progresses, it eventually impacts physical functioning such as walking, speech, swallowing, and muscle control throughout the body. And Alzheimer's is the most prevalent type of dementia. Cognitive impairment can result on a range of factors, including aging, neurological conditions such as Alzheimer's disease, Lewy body dementia, epilepsy, cancer of the brain, multiple sclerosis, and Parkinson's disease, vascular conditions including cerebral vascular accidents, TIAs, and vascular dementia, mental health conditions such as depression, anxiety, and chronic stress, delirium as a result of illness or infection, endocrine issues including hormonal imbalances, injuries such as concussion and severe head trauma, certain medications and treatments including but not limited to chemotherapy, sedatives, pain medications, anticonvulsants, antidepressants, antipsychiatric drugs, antipsychotic drugs, and anticholinergic drugs. Infections such as meningitis and encephalitis, chronic sleep deprivation, and genetic conditions such as Down syndromes and Huntington's disease. Signs and symptoms may include memory loss or difficulty remembering things, such as asking the same questions repetitively or telling the same stories over and over, struggling to learn new items, issues with following simple instructions and directions, difficulty concentrating, challenges with problem solving, impaired decision-making and judgment skills, difficulty recognizing familiar faces and places, including navigating areas they used to frequent, loss of interest in previously enjoyed activities or hobbies, difficulty completing ADLs and IADLs, including those that were once previously managed independently, struggles with finding the right words or language in general, changes in mental health, including depression and anxiety, and mood changes such as confusion, agitation, irritability, and aggression. Frequently, family and friends typically notice these changes before the individual affected becomes aware of them. These signs and symptoms may result in social isolation, loneliness, a reduced quality of life, and loss of identity for the affected individual. Now that we have a better understanding of cognitive impairment, let's move on to discuss CPT code Cognitive Assessment and Care Plan Services. CPT code 99483 is used for billing cognitive assessment and care plan services. This code includes the time and services required for evaluating cognitive impairment, developing care plans, and coordinating care for patients with cognitive conditions such as dementia or Alzheimer's disease. These services enable clinicians to identify cognitive impairments in their patients and, based on the underlying cause, assist in improving cognitive function or expanding essential support services. Medicare beneficiaries who are eligible for cognitive assessment and care plan services include individuals who are diagnosed with cognitive impairment, including those who have been formally diagnosed with conditions such as Alzheimer's disease, other types of dementia, or mild cognitive impairment, and people, although not clinically diagnosed, are assessed by the clinician to have cognitive impairment based on their judgment and observations. This may include patients showing signs of memory loss, confusion, or difficulty with thinking and reasoning, even if they've not received a formal clinical diagnosis. The healthcare provider can perform a cognitive assessment for a patient when there is an indication or concern suggesting cognitive impairment. One opportunity for the healthcare provider to perform this service is during the initial preventive physical exam, also known as the Welcome to Medicare visit. Assessment of cognitive impairment is also a required component of the annual wellness visit. Additionally, the healthcare provider may perform a cognitive assessment during any routine visit as needed. A routine visit is defined as any medically necessary E&M visit provided to the patient. Cognitive impairment can be identified through direct observation by the clinician, interviews with family members, friends, or caregivers, administering a brief cognitive test, such as the mini-cog, or evaluating health issues, chronic conditions, and other factors that may increase the risk of cognitive impairment. If signs of cognitive impairment are identified during either the annual wellness visit or another routine visit, Medicare will provide coverage for a separate visit to allow the healthcare provider to conduct a more thorough cognitive assessment and develop a tailored care plan. These services, referred to as cognitive assessment and care plan services, are specifically designed to address the patient's cognitive health needs in greater detail. The cognitive assessment and care plan services enable healthcare providers to comprehensively assess cognitive impairment, diagnose conditions such as dementia and other related disorders, detect and treat coexisting issues such as anxiety and depression, and create a personalized care plan to support the patient. According to Medicare guidelines, the cognitive assessment and care plan services can be performed by eligible healthcare providers. Eligible healthcare providers are those who meet specific qualifications and are authorized to conduct these assessments and create care plans for patients with cognitive impairments. These healthcare providers may include physicians, nurse practitioners, clinical nurse specialists, physician assistants, and any other healthcare provider who's eligible to report E&M services. Additionally, while clinical and ancillary staff may administer basic cognitive screening tools, cognitive assessment and care plan services are considered practitioner services and must be performed by an eligible healthcare provider. Clinical and ancillary staff are not authorized to independently perform these assessments or create care plans. The cognitive assessment and care plan services can be provided in several different locations, including office or outpatient setting, private residence, care facility, rest home, and via telehealth through two-way interactive audiovisual communication. The cognitive assessment begins with a thorough history and patient examination. An essential requirement of the cognitive assessment under CPT code 99483 is the presence of an independent historian to provide the patient's medical history, especially when the patient is unable to offer a complete or reliable history. An independent historian can be a parent, spouse, guardian, or another individual who is knowledgeable of the patient's medical history and can provide accurate and relevant information about the patient. This is essential to ensure the completeness and reliability of the medical history during both the cognitive assessment and care plan process. For a cognitive assessment under CPT code 99483, the clinician usually spends 60 minutes in a face-to-face interaction with both the patient and the independent historian. This time is used to complete all the components of the cognitive assessment. However, the exact duration may vary depending on the specific needs of the patient. There are several key areas of focus during a cognitive assessment. The Alzheimer's Association recommends a variety of tools for assessing each domain of the cognitive assessment. These tools, along with corresponding recommendations, are available on their Cognitive Impairment Care Planning Toolkit. Mary Sue is going to add a link to the chat to the Alzheimer's Association Expert Task Force recommendations and tools for implementation for you to review. Let's now take a closer look at each domain of the cognitive assessment in more detail. The first domain of cognitive assessment involves evaluating the patient with an emphasis on observing their cognitive function. The evaluation may involve directly observing the patient, as well as interviewing the patient, family members, guardians, caregivers, and other trustworthy individuals who can offer pertinent information. When evaluating the patient, it's important to consider other factors that may impact cognitive function, such as chronic medical conditions, health issues, and other relevant environmental or social influences. The Alzheimer's Association recommends utilizing various tools for assessing cognition, including the mini-cog, the general practitioner assessment, and the short Montreal cognitive assessment. These tools are designed to provide a structured way to evaluate cognitive function. Depending on the specific test selected, the patient will be required to perform a range of tasks. This may include memorizing and recalling words, naming objects, copying shapes, and drawing figures to assess their cognitive abilities in areas such as memory, language, and visuospatial skills. The next domain is to gather and examine the patient's history, reports, and records. The healthcare provider should thoroughly review relevant medical records to ensure an accurate and comprehensive understanding of the patient's medical background. This includes evaluating previous diagnoses, treatments, medications, and any other pertinent health information to provide a comprehensive background for the cognitive assessment. The third domain of the cognitive assessment involves conducting a functional evaluation of activities of daily living and instrumental activities of daily living, as well as assessing decision-making capacity. This assessment examines the patient's ability to perform essential activities of daily living, such as maintaining personal hygiene, bathing, dressing, eating, toileting, maintaining continence, transferring, and mobility. It's also important to assess instrumental activities of daily living, which include tasks such as shopping, preparing meals, arranging transportation, managing medications, managing finances, and housekeeping. Problems with IADLs can often be an early indicator of cognitive decline as they involve decision-making, planning, and complex problem-solving skills. Identifying these issues during this component of the cognitive assessment can help pinpoint areas where additional support is needed. This information guides decisions to provide extra resources that can improve the patient's quality of life. Tools for assessing function include the CATS Index of Independence in Activities of Daily Living and the Lawton-Brody Instrumental Activities of Daily Living Scale. Using standardized tools for staging dementia, such as clinical dementia rating and the functional assessment staging test, is the fourth domain in the cognitive assessment. The functional assessment staging tool, or FAST, is used to identify and classify the 7 stages of dementia, focusing not only on cognitive decline, but also a person's ability to complete activities of daily living. Unlike other scales that primarily assess cognitive function, FAST offers a more comprehensive understanding of dementia by emphasizing functional abilities. It provides clearer and more easily understandable descriptions of each stage. The FAST scale breaks down the progression of dementia into 7 distinct stages, which includes Stage 1, normal aging or no functional decline, Stage 2, possible mild cognitive impairment, Stage 3, mild cognitive impairment, Stage 4, mild dementia, Stage 5, moderate dementia, Stage 6, moderately severe dementia, and Stage 7, severe dementia. The next domain is to assess and review any high-risk medications if applicable. This involves evaluating the patient's current medication regimen to identify any drugs that may present higher risk for adverse effects or complications. High-risk medications could include those that require careful monitoring, have a narrow therapeutic window, or are commonly associated with significant side effects. If such medications are present in the patient's treatment plan, the clinician should assess the appropriateness of their use, review dosages, check potential drug interactions, and determine if any additional monitoring or adjustments are needed to ensure the patient's safety and well-being. The sixth domain of cognitive assessment involves use of standardized screening tools to assess neuropsychiatric and behavioral symptoms such as depression and anxiety. The Alzheimer's Association recommends using tools such as the Neuropsychiatric Inventory Questionnaire, or NPI-Q, Behave 5+, or the Patient Health Questionnaire 2, also known as the PHQ-2. The NPI-Q focuses on behavioral disturbances frequently observed in dementia, including delusions, hallucinations, agitation, and apathy. Behave 5.2 evaluates functional abilities related to activities of daily living. It is commonly used for patients with dementia. The PHQ-2 is a brief screening tool for depression that asks about symptoms of depressed mood and loss of interest. The next domain of cognitive assessment is to perform a safety evaluation. When performing a safety evaluation, it's important to assess potential hazards the patient may encounter both in their home and while operating a motor vehicle. The home safety evaluation should address issues such as structural issues of the home, such as loose steps or railings, absence of handrails on stairs, broken windows, or damage to the home's walls or supporting structures. Electrical issues such as loose wires or malfunctioning electrical outlets, fire safety issues such as non-functional smoke detectors, lack of fire extinguishers, or excess clutter blocking escape routes, and fall risks such as loose rugs, lack of grab bars or railings, or insufficient lighting. A comprehensive motor vehicle evaluation should address proper maintenance of essential vehicle components such as tire tread, lights and brakes, safe driving behaviors including avoiding distractions, refraining from driving when fatigued, and adhering to traffic laws and regulations, and environmental factors such as weather conditions and road hazards that may impact driving safety. The eighth domain of cognitive assessment focuses on identifying and evaluating social supports. This involves assessing the availability and effectiveness of family, friends, or other individuals who may assist the patient. An essential aspect of this evaluation is understanding the caregiver's level of knowledge regarding the individual's condition, needs, and appropriate care strategies. Additionally, it's important to assess the caregiver's willingness to provide ongoing support, considering factors such as emotional readiness, physical ability, and the resources they have at their disposal. This comprehensive evaluation helps determine the adequacy of the support system and ensure caregivers are properly prepared and able to meet the care needs of the individual. The last domain of cognitive assessment is to create, review, or update advanced care planning and evaluate any palliative care needs. Advanced care planning service is a voluntary face-to-face discussion between the healthcare provider, the patient, and the designated independent historian about advanced directives. The advance directive outlines the patient's preferences for medical treatment in the event they are unable to make decisions for themselves. The patient can choose to appoint a representative to make healthcare decisions on their behalf if necessary. Examples of advance directives include do not resuscitate orders, healthcare powers of attorney, healthcare proxies, living wills, instruction directives, medical orders for life-sustaining treatment, and psychiatric advance directives. Information on advanced care planning is available in MLN 909-289 Advanced Care Planning Fact Sheet. After completing the cognitive assessment, the healthcare provider should use any findings gained from the patient's history and examination to develop a comprehensive written care plan that addresses their specific needs. The information obtained from the cognitive assessment will be crucial in guiding the creation of a detailed written care plan, ensuring it reflects the individual's unique cognitive status and requirements. The healthcare provider should collaborate closely with the patient and their family and/or caregiver to create a personalized written care plan that incorporates their preferences, goals, and any necessary support or interventions. The care plan should include strategies focusing on neuropsychiatric symptoms such as depression, anxiety, apathy, agitation, irritability, delusions, hallucinations, and sleep disturbances, neurocognitive symptoms such as memory loss, trouble with attention and concentration, difficulty of problem solving, trouble with verbal and written communications, and difficulty with task completion, functional limitations such as difficulties in performing ADLs and IADLs, and referrals to community resources such as rehabilitation services, adult day programs, and support groups as needed, along with initial education and support. The written care plan should summarize the assessment findings in clear and simple language. It should outline who is responsible for each recommended action and include a schedule for initial follow-up. It must be reviewed with the patient and/or their family or caregiver. The details of this face-to-face discussion must be documented in the medical record for all encounters billed using CPT code 99483. The care plan should be stored in the patient's medical record where it can be easily accessed and updated. Make sure to provide a copy of the care plan and referrals to both the patient and their family and/or caregiver. Additionally, when completing documentation for the cognitive assessment and care plan services, ensure the medical record contains documentation of medical decision-making of moderate to high complexity as defined by E&M codes and guidelines. This is necessary for meeting the requirements for billing CPT code 99483, which involves thoroughly assessing cognitive function and developing a personalized care plan based on the patient's cognitive status. To document moderate to high complexity medical decision-making for cognitive assessment and care plan services, the healthcare provider should clearly outline the patient's cognitive history, conduct a comprehensive cognitive assessment using standardized tools, and consider multiple differential diagnoses. The provider must also evaluate the risks and benefits of various treatment options based on the patient's cognitive status. Furthermore, the documentation should include detailed rationale for the chosen care plan, which may involve referrals to specialists, recommendations for additional support services, and strategies for assisting the patient and caregiver. Finally, ensure each component of the cognitive assessment and care plan services is clearly documented within the medical record. This includes documentation of all tests used for cognitive assessment, along with their corresponding results. We will now conclude by discussing billing of CPT code 99483, cognitive assessment and care plan services. As mentioned earlier, the assessment of cognitive impairment is a required component in both the initial annual wellness visit and subsequent annual wellness visit, and is billed under G0438 for initial annual wellness visit or G0439 for subsequent annual wellness visit. This screening does not require separate billing beyond the standard annual wellness visit codes. However, if the healthcare provider identifies a cognitive impairment during the annual wellness visit, or if the patient exhibits signs of cognitive impairment, such as dementia or Alzheimer's disease during a routine visit, Medicare will cover a separate visit for a more comprehensive cognitive assessment and development of a care plan. In this scenario, the healthcare provider should use CPT code 99483 to bill for cognitive assessment and care plan services. Please note that Part B coinsurance and deductible apply to services billed under CPT code 99483. CPT code 99483 can be billed separately from the annual wellness visit, which means the annual wellness visit and the cognitive assessment and care plan services can be treated as distinct services for billing purposes. If both the annual wellness visit and the cognitive assessment and care plan services are provided during the same visit, it is necessary to add modifier 25 to CPT code 99483 on the claim. This modifier indicates the cognitive assessment and care plan services are separate and identifiable services, distinct from the routine elements of the annual wellness visit. Using modifier 25 ensures the services are appropriately reimbursed without being bundled into the annual or the standard annual wellness visit code. Healthcare providers are not permitted to bill 99215 office or other outpatient visit for evaluation and management of established patients alongside CPT code 99483 cognitive assessment and care plan services on the same day. This is because the services are considered overlapping according to Medicare guidelines, which means they cannot be billed together. Simply put, if a high-level E&M visit, such as a CPT code 99215, is performed, you cannot bill for a comprehensive cognitive assessment on the same day, since both services involve similar level of complexity and scope. CPT code 99483 already includes key components typically found in the Level 5 E&M visit CPT code 99215, such as a comprehensive history, comprehensive exam, and high complexity medical decision making. These components are integral to CPT code 99483 and align with what is typically required for a Level 5 office visit, making it inappropriate to bill both codes for the same visit. However, providers may bill CPT code 99483 in combination with HCPCS code G2212, which covers prolonged office or outpatient E&M services if the visit extends beyond 60 minutes. This allows for billing additional time spent on extended evaluation and management services during the cognitive assessment, which is necessary if the visit is particularly lengthy or complex. Healthcare providers cannot bill for the following services on the same day as CPT code 99483. 90785 Psychological Complex Interactive, 90791 Psychological Diagnostic Evaluation, 90792 Psychological Diagnostic Evaluation with Medical Services, 96103 Psychological Testing by an Administrator, 96120 Neuropsychological Testing by an Administrator, 96127 Brief Emotional and Behavioral Assessment, 99201 through 99215 Office Outpatient Visits, 99324 to 99337 Home Visits with New Patients, 99341 through 99350 Home Visits, 99366 through 99368 Medical Team Conference, 99497 Advanced Care Plan First 30 Minutes, and 99498 Advanced Care Plan Additional 30 Minutes. Mild cognitive decline is a normal aspect of getting older. However, cognitive impairment that impacts a person's ability to live independently and function effectively is not. During today's webinar, we covered the Medicare guidelines for CPT code 99483, cognitive assessment and care plan services, including background information about cognitive impairment, Medicare coverage criteria and documentation guidelines for CPT code 99483, cognitive assessment and care plan services, and billing of CPT code 99483, cognitive assessment and care plan services. I've included two resources from the CMS website on this slide. The first resource is a link to CMS's Cognitive Assessment and Care Plan Services webpage. The next resource is a YouTube video created by CMS about Cognitive Assessment and Care Plan Services. Please refer to this slide and use it as a reference when reviewing the presentation. We are now at the end of the formal presentation. Please remember, if you have any questions, please put those questions into the chat feature and select Send to all panelists. Before we go to questions in the chat, I want to address a couple pre-submitted questions we received. If you don't get your questions today during the presentation, we will send on a document to all participants with the answers following this webinar. So question 1 asks, how would billing for a cognitive assessment work in an RHC when done on the same day as an annual wellness visit or other E&M visit? In a rural health clinic, when a cognitive assessment and care plan services are provided on the same day as an annual wellness visit or another evaluation and management service, both services may be documented and submitted. However, Medicare does not allow separate reimbursement for CPT code 99483 when it is performed on the same day as an annual wellness visit or an E&M visit. In the RHC setting, all services rendered on the same day are bundled into a single encounter and reimbursed under the all-inclusive rate. Even if both services are medically necessary and separately documented, only one payment is made under the all-inclusive rate, meaning no additional reimbursement is provided for the cognitive assessment when delivered on the same day as another qualifying service. If the cognitive assessment and care plan services are performed on a different day as a standalone visit, they may be billed as an RHC encounter and are eligible for reimbursement under the all-inclusive rate. Question 2 asked, is CPT code 99483 Cognitive Assessment and Care Plan Services a time-based code? CPT code 99483 for Cognitive Assessment and Care Plan Services is not time-based, but rather service-based. This means it's billed based on the completion of specific components, not on the amount of time spent. Although the service typically involves about 60 minutes on the day of the visit, this duration is not a billing requirement. If the visit exceeds the usual time, prolonged service codes such as G2212 can be reported in addition to 99483, as long as all criteria for prolonged services are fulfilled. And I do see we have some questions in the chat. I'm taking a look at one of them. The Cora had asked that she did not understand the moderate to high complexity for billing of 99483. Can I explain further or give a reference? So give me a second on that one. Okay, for care planning for cognitive assessment care plan services, it is billed as a it is considered a moderate to high complexity billing. When you do moderate to high complexity billing, it involves a higher degree of decision making. And the CPT code 99483 Cognitive Assessment and Care Plan Services does require that extensive decision making and requires more thorough assessment and a complete assessment. I can send out, and I will send out a document to all participants, and I'm writing this down right now, with the E&M guidelines so you can see a little bit further, Cora. Maybe you can see some examples that CMS does give on that. So I will send that out to all participants, but I'll obviously include you in that email, so maybe that can help you with getting a little bit more context. Okay, and then she said, if the medical decision making is not moderately to high complexity, 99483 cannot be billed. And as long as you are completing all the components of 99483, then yes, it can be billed. When you do complete the cognitive assessment and the care planning services and complete all those steps, you are doing a moderate to high complexity level of care. So as long as you're fulfilling all the requirements of 99483, cognitive assessment and care planning services, then you can bill for that. But do make sure you do all of those components that are necessary. Okay, and let's see. The next question is from Rachel, and she says, is the same for FQHCs? And I'm assuming that she's referring to the RHC question. I do know that FQHCs do use PPS, their own PPS for billing, but I'm going to have to look a little further into that one. So I will get back to all of you, and I will discuss the regulations or send out some information about the regulations for FQHCs when it comes to 99483, because I don't want to give you anything that, or not give you a complete answer on that one. And I'm looking through the questions. And okay, and that's all I have. Mary Sue, did you see any other questions in there? Oh, I'm sorry.
Looks like you got everything covered so far.
Okay, well then I'm going to go forward. For those attending today's live event, in a few minutes, you will receive an email thanking you for attending. And the email will look sort of like what you see on your screen. Do not delete it without reading it. This email contains your certificate of achievement, as well as a link to take the survey. And if you haven't completed it already, please take a few moments to complete the customer satisfaction survey. The contact hours for this event can be found in this email should you require them for earning credit through continuing education units. If you don't see it, please check your junk or spam folder. Make sure to add the WebEx email address messenger@webex.com to your safe sender, safe receiver list to avoid these emails going to junk or spam. If you called into this webinar, you won't automatically get this email. So just email us at wps.gha.education@wpsic.com with the name of this webinar and the phone number you used to log in, and we can email you your certificate of achievement. Again, if you logged on and you are in it on your browser, you should receive this email. This is just for people who call in and are not able to see the webinar on their browser. Following today's live event, if you think of any additional questions, you have 7 days from today to submit them. Send them to our education mailbox at wps.gha.education@wpsic.com and put Cognitive Assessment and Care Plan Services in the subject line. However, if you have claim-specific questions, please do not send those to Provider Outreach and Education. Please direct those questions to our customer service department, as we do not have access to your claim information and therefore are unable to look up claims. Also remember, we cannot accept any type of PHI or PII via email. If you haven't done so already, please take a few minutes now to complete a survey. Share with CMS and us about your experience today. Tell us about your experience, including what you liked, what we could do to improve, and suggestions for future education. Your feedback really is invaluable in helping us deliver education that you need. We use your feedback to develop topics for future education. There are several different options you can use to take the survey, depending on your preference. For those attending today's live event, the first option is to click the survey link in the chat. The other option is to take the survey on the CMS Qualtrics page. When you exit the webinar, you will be asked to go to an external site. And that external site is the CMS Qualtrics page for the survey. And the message will look sort of like what you see here on your screen with the little yellow triangle. That site is not spam. It's actually directing you straight to our survey. And we will also add a survey link to the Encore presentation. Just click on the survey picture at the end of the Encore presentation video to take our customer satisfaction survey. On behalf of myself, Mary Sue, and all of Provider Outreach and Education, thank you for attending today's webinar on Cognitive Assessment and Care Plan Services. As a reminder, this presentation will be posted as an Encore presentation on the Training Center page on our website. Remember to take our survey with the link provided. We look forward to your survey comments and hope to have you join us at future events. You may now disconnect.